Good afternoon or good morning, everybody. My name is Shamir Smith, and on behalf of Body Politic, I am so excited for another one of our live events. Today, we're going to be talking about the neurological complications of COVID with a very, very special guest. I, as some of you all know, am a long COVID patient advocate turned consultant for Black long COVID patients in urban communities. And I am just very, very excited to continue forth the mission of Body Politic, along with another host, Angela Mariquez Vasquez. And I'm going to tell you a little bit about Body Politic. Through a global network of COVID-19 patients, chronic illness allies, and health and disability advocates, Body Politic continues to break down barriers to patient-driven whole person care and well-being, particularly for historically marginalized communities, by facilitating peer support, cultivating patient-led research and public education, and leading community-based advocacy. We are so thankful and grateful today to have Dr. Nath here. He has been one of the leading neurological experts and researchers on the effects and the implications of COVID on the brain. And we are so excited to have him here. And I'm going to tell you a little bit about Dr. Nath before he presents to us today. Dr. Nath received his MD degree from Christian Medical College in India in 1981 and completed a residency in neurology from the University of Texas Health Science Center in Houston, followed by a fellowship in multiple sclerosis and neurovirology at the same institution, and then a fellowship in Neuro-AIDS at the National Institute of Neurological Disorders and Stroke. He held faculty positions at the University of Manitoba from 1990 to 97 and the University of Kentucky from 97 to 2002. In 2002, he joined Johns Hopkins University as professor of neurology and director of division of neuroimmunology and neurological infections. He joined the NIH in 2011 as the clinical director of the NINDS, the director of the Translational Neuroscience Center, and chief of the section of infections of the nervous system. His research focuses on understanding the pathophysiology of retroviral infections of the nervous system and the development of the new diagnostic and therapeutic approaches for these diseases. Dr. Nath, without further ado, we'd like for you to present, and we're glad to have you here today.
Thanks, Shamir, for the very kind introduction. And I want to thank the Body Politic for inviting me to present at this forum. I was really looking forward to it. And I want to also thank Marissa for the invitation. So yes, as you mentioned, my career has been focused on understanding infections and how they affect the brain, and started off with AIDS. And then, there was a major pandemic, still hasn't finished. And then we've had one pandemic after another. It's been dengue and Zika and Ebola and so on and so forth. And they just keep piling one on top of the other. And then comes SARS. So as you can imagine, my life has just been taken over by SARS at the moment. But we've learned a lot. I think the most important thing we've learned is that early on, people forget that the brain is involved by these infections because we get focused on other aspects. But and eventually what we realize is that the other organ systems, while important, they're eventually treatable. What remains is really the effects on the brain. So the main socioeconomic consequences of this infection are largely related to effects on the nervous system. So let me go ahead and share my slides. And so I'll plan on speaking for the next 40 minutes or so. And then after that, I'm happy to take questions for however long. Okay, so let's do this. I'm just going to go to the first slide here. So as Shamir mentioned, I work at the National Institutes of Health, and which is in Bethesda, which is right next to Washington, D.C. Okay, and so, oops. Let me just do this here. Okay, so the in this building here that you see, there are actually three buildings put together, is the in the clinical center here. And that's where we bring in patients for research purposes. This is the largest research hospital in the world. And so we don't have an emergency room. We don't have a neuro ICUs. And nobody can just walk in and say, please take care of me. The only way we can see patients are they come in for research purposes. So we're very grateful to the patients who come, because most often, and they are volunteering their body for research, and with no guarantee of what the outcome will actually be. Okay. So I want to start with this quote. Many of you may not know who Sir William Osler was, but he was the person who shaped modern medicine. And he used to be chair of internal medicine at Hopkins. And in 1896, he addressed the American Medical Association in the Carolinas. And at that time, he made this statement. He said that humanity has but three great enemies: fever, famine, and war. And of these, by far the greatest, by far the most terrible is fever. Okay. And that holds true even today, because if you look at the people who die from famine and war, and you combine them all together, it pales in front of those people who die of infections. Okay. The biggest threat to humanity is from infections, and not from war or famine. And not that war and famine aren't bad. I mean, they shouldn't occur either, but this is the greatest threat. But the thing is that it never really reaches the public eye as much. Except for now, it's received a lot of attention. But if you look at the way human race has been shaped, it's been through infections. There comes a wave of infection that kills off huge populations of people. Few remain on the planet. They repopulate the planet. Then comes another infection, wipes out a whole bunch of people, and so on and so forth. And that's how we've been evolving over a period of time. Okay, but in the modern era, this shouldn't really happen. But unfortunately, we never learn. Okay, so this is from 2017 on the cover of Times Magazine, and this is at the time of the Ebola epidemic. And so it has a warning. It says we are not ready for the next pandemic. 2 years later, you have SARS-CoV-2, COVID-19, right? And we find ourselves totally unprepared. We have no idea how to handle that infection. And we receive lots of warnings. This can happen, this can happen, this can happen. But yeah, when it happens, we're all surprised, right? So at some point, we have to learn. Now, if you just look across the globe, you'll find there are lots of pandemics that have occurred. Zika virus devastated all of South America. Ebola, West Africa. Acute flaccid paralysis here that occurs in children every 2 years in many different countries in Europe and United States. Okay, still don't have anything for these diseases. Dengue, parts of Asia and Africa, kills millions of people every year. But yet, if you look at all these diseases, what do we have for treatment anyway? Nothing. We have no treatments for most of them. We have no vaccines. We have nothing available. And they kill huge numbers of people every year. But yet, there's no attention has been paid to these things. You look at HIV, okay? It still continues to this day. Now, some of us may be old enough to remember this well, but in the 80s, caused a lot of social unrest. And this is a consequence of what happens. I mean, you can see with COVID, how much social unrest has taken place in this country. And you haven't seen the end of it yet. There are 130 countries around the world that have not vaccinated a single person yet. Okay. So we haven't seen the actual devastation on this planet by this infection to this day. But there are huge consequences. You can have huge social unrest. Okay. As you can see over here, you can see this is a picture of the Capitol building and the mall. And on the mall, you have this blanket here. Okay. It was called the AIDS blanket, or the quilt, sorry, AIDS quilt. And each piece of this quilt represented a person who had died of AIDS. Eventually, the quilt became so big, the mall even couldn't hold it any longer. Okay. And we still don't have a vaccine or a cure for HIV. We have drugs that can manage it to some degree, but that's about it. And then comes COVID-19, same mall, different era. Okay. This is at the inauguration of President Biden. And you can see this time they have flags. They have flags of 400,000 people at the time of inauguration. That was 22nd of January. Within a month later, in end of February, there were 500,000 people had died. In 1 month, 100,000 people had died. Okay, so the current deaths are estimated to be somewhere between 800 to 900,000 people. Huge numbers of people have died, and at this peak, 4,000 people were dying per day. So the big disconnect is that viruses each year cause devastation in epidemic proportions. They spread rapidly, and historically, by wiping out large populations, they've shaped the evolution of humans. Theoretically, they could threaten the existence of humans on this planet, right? And yet, our therapeutic options are very limited. We have some drugs to treat herpes viruses, maybe some hepatitis, and some that control HIV to some degree. But that's it. And there are thousands and thousands of viruses that affect humans, and we have nothing for them. If you look at coronaviruses, which is one that SARS-CoV-2 is part of, there are several coronaviruses that infect humans, and every coronavirus that infects humans causes neurological complications. Okay, all these viruses affect the brain. Okay, what do they do to the brain? So there are lots of things that can do to the brain. So largely, you can divide them into two types of complications. Okay, so one we call as para-infectious, which means that these are infections that occur during the acute phase of the illness. So that means that when you have the flu-like symptoms and the fever and stuff, and right at that time, it can affect the brain in many different ways. You can lose smell. You can affect the brain and lose cognition. It can cause strokes. Strokes is huge with COVID. Okay, it affects the blood vessels in many different ways, and I'll go into some more detail. It can cause meningitis and encephalitis. It can cause seizures in patients. It can affect the white matter in the brain. It's called leukoencephalopathy. That means the myelin and other things are degrading. And then there's an interesting phenomenon called Ondine's curse. So it can cause sudden death in people. And I'll show you some autopsy specimens of people who died suddenly. And this, again, doesn't receive a lot of attention. And the dead people have no voice, unfortunately. But it's caused a lot of people to die suddenly from the infection. Okay. So then you have these so-called post-viral syndromes. And you hear a lot about these, okay? And you hear a lot about them because these are people who survived the acute infection, and now they have all kinds of problems, right? So these are largely immune-mediated because what happens is that after the acute infection is over, the song is gone, but the music lingers on. And this is what is lingering here. So, and I'll go into these in some more detail, but it can affect every aspect of the nervous system, the brain, the spinal cord, the peripheral nerves, the muscle, and in fact, the whole gamut. Okay, let's skip this one. So I talked about encephalopathy. So this is in the acute phase of the illness. And what happens is that if you look at patients who are hospitalized, they'll have change in their mentation, about a third of them can't think or concentrate properly. And those individuals who have effects on their brain, they are in the hospital for long periods of time. Okay. And at the time when they're discharged, they still can't handle their own affairs. Yeah. And it's not related to the amount of damage to the lungs. It's independent of that. It means a direct effect on the brain in some ways. And it does occur in older male individuals, but nobody is spared. Okay. And the mortality rate of these individuals is 6 times higher. So effects on the brain have major consequences, right? And these are not only to the patient, the socioeconomic consequences are also huge. And this is the leukoencephalopathy I was talking about. So if you look at the brain here, these patients who are hospitalized, all this, so this is a section of the brain right from the top. And so this is the front of the brain, and this is the back of the brain. And so what you see is where I have these arrows here you can see all this white stuff. This is all abnormal. Okay, so this is called leukoencephalopathy. Oops. And you can see here at the bottom too. It's a different way of looking at the same scan here. Okay. Now the interesting thing is that the virus infects the nose. Okay, so all the nasal mucosa is affected. Now the nose is right beneath the brain. So the question people have always asked, is it possible that the virus can go from the nose to the brain? Okay. And certainly in case of animal studies with different other coronaviruses, that's been shown to be the case, that it can go from the nose to the brain. But for SARS-CoV-2, that's not the situation. Okay. So a way that the virus is going to enter any kind of cell, it has to bind to a receptor. Okay, viruses have to bind to something. And so you all heard of the spike protein, right? The spike protein is on top of this virus, and the spike protein binds to the receptor, and the receptor is called ACE2, angiotensin converting enzyme. The thing is that this receptor is not present on neurons. Okay, it's present on other types of cells, but not the neurons. So if you look at the different types of cells in the nose, so what you see is this red one with these little things coming off like roots over here. This is your neuron in the nose. Okay, this is how you smell. But this is not infected with the virus. There are these other cells around them. Okay, these are called support cells, and one of them is called sustencular cell. Okay. This has a lot of ACE2 receptor on it. So the infection occurs in these support cells. It produces huge amounts of virus. Okay, and because those are infected, it causes swelling in the nasal mucosa, and that compresses these nerves, and it can cause damage to them. So the damage to the nerves is secondary, not primary from the infection. Okay. And here, if you look at this electron micrograph here, you see these small dots over here. Each one of them is a virus. Okay, so you can see this little section here, how much virus is coming out in this small area. Okay, so the amount of virus that comes out of the nose is huge. So if you wear a mask and you don't cover the nose, it's useless. You got to cover the nose because all the virus is coming out of the nose. Every time you breathe, there is like plumes of virus coming out of your nose, plumes of it. Okay, so and anyhow, this is just to show that I'm staining for the receptor, showing you which cells I have the receptor on here. Okay, so what we did was we got brains from New York, and the New York Medical Examiner's Office was very kind to share autopsy brain tissue from patients who had died. Now, the interesting thing about the patients that come to the medical examiner's office, these are usually medical legal cases, people who die at home or stuff like that. So the patients that we got, these were relatively young individuals who were found dead at home. Okay, so and there was nothing much wrong with them. They never went to the hospital or sought medical attention because they were sick. They had minor symptoms, but they thought, nothing of it. And they were at home, and all of a sudden their partner or spouse or whoever found them dead in their bed. And one person was found dead in a subway. Another guy was just playing with his sister, just up and down, and just dropped dead. Okay, so these guys were otherwise relatively healthy. When we looked at their brains, we were very surprised. There was a lot of pathology in them. The way they found out they had COVID was the medical examiner's office did a nasal swab on all of them, and they were positive. So that means they had acute infections. Okay. But, So when we looked at the brain, so this is what is called the olfactory bulb. Okay. So this is where your nerves from the nose go into the bulb. So we said, okay, if the virus goes through the nose, we should find it here. Right? And the thing is, we never found any virus, but we found a lot of pathology. Okay, so when you look at it here, you see all this in panel C here. You see this green stuff here, just hazy green stuff on it. This is a protein called fibrinogen. And this protein is present only in the blood. It's never been in the brain. It's a big protein. It doesn't get through the blood vessel. The only way it can get through the blood vessel is the blood vessel has to be damaged. Okay. And so when we saw this in the olfactory bulb, okay, that told us immediately these blood vessels, something wrong with the blood vessels. So we then stained the blood vessels, and you can see these blood vessels. We have the arrows. Those are parts of the blood vessel that are not staining. You can see this missing dark kind of areas here. And that is because these blood vessels are damaged. And the areas where the blood vessels are damaged, that's where you see the leakage of the proteins. But that's not the only thing we saw there. We also looked at it and see all these brown staining cells here. These are all macrophages. Okay. So there are all these immune cells are getting in there too. Okay. So there's a lot of inflammation taking place, damage to the blood vessels, seepage of proteins, right? All this happening over here. So there's a lot of pathology, but it's not directly caused by the virus. It's indirectly going in. Okay, so the message that I want to convey to you that the primary target of the virus are the endothelial cells in the blood vessel. The blood vessel has all kinds of cells in there, but the lining of the blood vessels is the endothelial cells. And it's the lining that is affected by the virus. And that's what causes all the pathology. So this is a CT scan of a patient. Okay, so again, the top part is where the front of your head is, the bottom is the back part of your head, and they're making sections from the top. Okay, so you see where this arrow is, this dark area, this is a stroke. Okay, that means there's no blood supply coming here. That's a stroke. On the other side here, where you have this arrow at the bottom, you can see another small area here where there is a stroke. So you got strokes on both sides of the brain. That's very unusual. Usually when people get strokes, you get it on one side, not both sides. Okay. The other interesting thing is that here's another patient, and you see all this black stuff here. This is an MRI scan. On an MRI scan, you see these black dots here. That's the equivalent of bleeding in the brain. So not only do they have strokes where there's decreased blood supply, the blood vessels are also compromised in other patients where you can get hemorrhages in the brain, right? So you have both phenomena. And this is in some of the autopsy specimens, you can see these small bleeding areas here, all the blood over here. You can see this bleeding over here, and a lot of congested blood vessels. And then these white spots here suggest inflammation in the brain. So in the same individual, you can get all kinds of pathologies. Okay, so I'll show you an example of that in just a bit. The other thing you can get is you can get clotting in the veins and the blood vessels. So these are called the sinuses, and this white stuff here is a clot. So you heard that with the J&J vaccine, they have to stop it for a while because these people develop very unusual strokes. This is the kind of strokes they were developing, was clotting of these blood vessels in the top of the brain, which is called the sinuses. But SARS itself can do the exact same thing. With COVID-19, you can get the exact same thing. Now, this MRI is interesting because in this individual, I want to show you 3 types of pathologies in the same individual. Okay, so these white spots are infarcts. That means there's decreased blood supply to the brain here. These dark spots are hemorrhages. That means there's bleeding of the brain. And then you see this blood vessel. You can see that on the wall of the blood vessel, you have this white stuff that is enhancement because this patient was given contrast. So you have an enhancement of the middle cerebral artery here. So that suggests inflammation. So you got an infarct, you got bleeding, and you have inflammation of the blood vessels, all in the same individual. Now that is quite amazing. Okay, we've never seen this kind of pathology before. So it's a very unique type of pathology, but can really devastate the brain in many different ways. Okay, so this is another brain section, but this is from the brainstem called the pons. So it's deep in the brain. Okay, and what we did was we stained it for fibrinogen. I showed you that diffuse green stuff there. This time the fibrinogen is brown. And you can see that there are small blood vessels here. These holes that you see here are blood vessels. Around these holes, you can see there's very dark staining. And then if you move a little bit further out, you see more diffuse light brown staining. Okay. But in total, if you look at the brainstem here, there's a huge part of it that's full of fibrinogen. And there should never be any of it there. And this is that same olfactory bulb now stained differently. You can see the amount of fibrinogen leakage in the olfactory bulb. Huge amounts of fibrinogen. Now, when we looked at the blood vessels a little bit more closely to see what's happening there, we found that there are these platelets. Platelets are these very small cells. You have RBCs, called the red blood cells, and you have platelets. And the platelets, once they get activated, they'll form clots. So you can see all these brown ones are activated platelets. And you can see this blood vessel is totally occluded. You have activated platelets here sitting on the blood vessel here. And you can see this one is like totally occluded. So it's partially occluded over here. This is an interesting one at the bottom because you can see some platelets here sitting on the wall. And then you have these branches of the coming off of the blood vessel, and those are totally clogged, right? So that's how these clots are taking place. I'm going to skip this one. Adults are not the only ones. And we think that children are less susceptible. That's not true. And devastating manifestations in children. I have several children that I got autopsy specimens from, and these children died from COVID, and they receive very little attention. They say, oh yeah, nothing's going to happen to children. We should open the schools and let them go and all that kind of stuff. Biggest mistake ever. This is one of the syndromes that these kids are developing, these poor kids now, are called multi-system inflammatory syndrome of COVID. It's called MIS-C in children. And there's a form that occurs in adults. We call it MIS-A in adults, A for adults. Okay. So what happens to these children? They develop a fever, rash, vomiting and stuff. They recover from it. Then a couple of weeks later, they become encephalopathic. So now they can't think or concentrate. And they develop weakness. They can't speak properly. They can't swallow. And their limbs get weak. If you look at the MRI scan there, you see at the back of this brain over here, this white stuff, this is totally abnormal. Okay. So they have abnormalities in the brain. If you look at their blood, it suggests inflammation in the blood, a lot of inflammation. And the brain is not the only one affected. Lots of organs are affected in these children. Right? So it's a multi-system problem. And you can treat them with steroids, but they'll get some effect, but not a lot. So it's a huge problem. And children affected at this age, for a lifetime, they will have problems. Okay, now there's not one picture that fits all in these patients who have COVID. And so even after they recover from COVID, they can get different types of manifestations in the brain. Okay. So they can get what is called viral encephalitis, where the virus itself is attacking them. It's very, very rare, very rare. Just one or two cases where you actually find the virus. But when you do, it's really bad because these patients develop lots of seizures. They lose consciousness. Their neck becomes really stiff. Okay. So it's very devastating, but fortunately, it's extremely low. What they do develop is this immune-mediated encephalitis. Okay. So you can get these enhancing, you see these round, white, round enhancing kind of structures over here. That's inflammation in the brain. And so you have lots of these where these arrows are. So you can get these focal areas of inflammation in the brain. And this is a spinal cord here. From top to bottom is the spinal cord. And in the middle of the spinal cord, you see this white spindle-shaped structure. That's abnormal. Okay, so you get inflammation in the spinal cord also, in your spine. And then there's another type of inflammation that occurs deep in the brain. This is the area called the thalamus. And so the thalami are affected through inflammation, and there's bleeding along with it. And with the mechanism of these two phenomena is totally different, and the treatment would be very different for each one of them. Okay, but the importance of recognizing these things. So this is a paper from Spain, and what they did was they presented these 5 patients here. Okay, So the top three, what you see is you see these arrows, you see these small dots here. So the term we often use is called punctate lesions, punctate being small. And they are enhancing, okay? These patients were sitting in the ICU for over 2 months, and they had all kinds of neurological problems, but they hadn't done anything about it. And then they had two others that had lots of dots. You can see almost, more diffuse involvement of the brain. What they decided to do was they said, well, let's treat them with corticosteroids intravenously, okay, and do what is called plasma exchange. Okay, you take out a liter of the plasma and you put in fluids back. Okay, and so when they did that, what they found was that the three individuals here responded fairly well to the treatment. The ones that had more diffuse or effects on the brain, they didn't do too well and they died. Right. So what it tells you is that you don't want to give up on your patients, even if it's been out 2 months or whatever. You should still give them a chance and see if you can reverse the process. If it's caused by inflammation, you actually could still salvage a lot of the brain. Okay, we looked further into the brainstem. So remember I told you that a lot of these patients that died suddenly. And so we wanted to find out, why did they die suddenly? Is it possible that the brain controls the way you breathe? And are the areas where the breathing is controlled by the brain, are they affected or not? That was the question we wanted to ask. And the answer is yes. Okay. So in the brainstem, you have a lot of different what are called nuclei. And amongst them, there is one called the pre-Bartzinger complex. Okay, this little dot over here structure is the pre-Bartzinger complex. So what we did was we did MRI scans of the brainstem, identified the area, then made sections from them and looked at them under the microscope. So I'll just point to you over here in this panel F. And in here, you can see, this is the pre-Bartzinger complex. And what I want to show you is all this brown staining are these macrophages or microglia in the brain. Okay, so these are inflammatory cells. But they're surrounding these neurons. So you see these bluish, reddish kind of cells here, fairly large. Those are neurons. Okay, so here at the bottom, you can see it a little bit better. So you see this neuron here, it's not healthy. Okay, and these blue dots around it are these activated cells. And so they're chewing up the neurons. So these neurons are damaged in the pre-Bartzinger complex. So that tells me that it's quite possible that the sudden death may have occurred by problems in the brainstem. Another possibility is they probably could have had a cardiac arrhythmia and died from it too. Okay. But here you can see more neurons here and being engulfed by these macrophages. Here's another one. Okay, so I showed you that there were these macrophages in the brain, and this is a group from Germany that showed the same thing. They also did an autopsy series, and they found a lot of macrophages around the blood vessels of the brain. Okay, so, and it's a common theme. These are the Swedish guys, and what they did, they looked for things that the macrophages produce. They produce all kinds of things, and you can find them in the spinal fluid. They measured them and found that, yes, they were also elevated in the spine. So the picture is very clear that most of this damage in the brain is being mediated by macrophages. So once you identify the cell type, now you can develop ways of being able to block it. But that's the key observation here. So I told you two things that are very important, okay? One is the blood vessel, damage of the blood vessel. The second thing is particular cell type that's going into the brain are the macrophages. And you want to block those macrophages. Prevent the damage to the blood vessel and block the macrophages, okay? And that's important because all these survivors that we have, somewhere between 10 to 30% of individuals at 6 months post-COVID are complaining of what we call as this long haul COVID or long COVID, okay? And so these are individuals who had relatively mild infection. They weren't hospitalized, right? They were at home for the most part. Or if they were hospitalized and didn't have very serious illness. But they now complain of a large variety of symptoms. And it's hard to put it all together. But what I've done is I've divided them largely into 3 buckets. The other thing I should point out is that This occurs predominantly in women, though not exclusively in women, by 4 times more women than men. And the average age is about 40 years. So you can see if you have a segment of the society this is the most productive life span and the age group. And so if they are affected, the socioeconomic consequences are huge, because these people are no longer in the workforce. They have young families, and it's the burden is huge. So, but what are they complaining of? You can put them in 3 buckets. Okay, the first bucket is what I call this fatigue or headache stuff. So the fatigue is very unusual. What they complain of is exercise intolerance. So that every time they exercise, they get extremely tired. But if you look at their heart and lungs and everything, no problem with that. They all appear to be normal, but yet they complain of these symptoms. Then there's some that complain. In fact, let me tell you, there was a cardiologist that I talked to, and she said that every time she climbed a flight of stairs to where her office was, she got totally wiped out. She couldn't even do telemedicine any longer. That was how severely she was affected. Then there are patients who complain of brain fog. What they mean by that is they have difficulty remembering names, and they have difficulty remembering time. That's the other interesting phenomenon. So one guy I talked to, what he told me was that he said he could remember what he ate for breakfast. What he couldn't remember is when he ate it, whether it was today or yesterday or a week ago. Okay. So the objects he remembers, but the time he doesn't. And there are also psychiatric manifestations. People have anxiety, depression. Few people can develop psychosis. It's not that common, but they can develop psychosis too. And I'll give you, and these are individuals who didn't have a previous history of psychiatric diseases. So one guy who worked at the institution where I am at NIH, and I talked to him, and what he said was that, and he's in his 50s. He never had any previous psychiatric problems. And he said all of a sudden he had suicidal ideations. He got scared of his own self. And so he admitted himself in the hospital. And he was there for over a month. And then he got discharged. And he's doing much better now. But at least he had good insight. So he sought help. If you don't have insight, you end up killing yourself. Then there's a third group of individuals that have what we call is dysautonomia, POTS syndrome. They complain every time they stand up, they get dizzy after a while, and their heart starts to race. That's the other symptom they got. One woman I talked to, she was a physician, and she told me that she had to lie down in bed in order to talk to me, because every time she even sat up, her blood pressure will fall and she couldn't think any longer. Some patients will complain of fever and joint pain, chest pain, difficulty with sleeping. And there's overlap between these 3 syndromes. So they're not exclusive of one another, but one can be more dominant than the other. Okay, so I'm going to skip this one. And this is just to show, and the way this works is that this is the POTS syndrome that I talked to you about. So these are individuals, here's their heart rate. You stand them up, and all of a sudden their heart rate goes up, went up to 155 beats per minute. And the blood pressure fell. You see that? So this is the blood pressure tracing on top. The blood pressure falls, the heart rate goes up. In this individual, it's quite erratic. The heart rate went up and the blood pressure went up too. However, these lines have the systolic and diastolic pressure. The margin between the systolic and diastolic really increased a lot. So there's increase in systolic pressure. Okay, now this is something called a PET scan. PET scan is where you can now measure, you give glucose, and the glucose is radioactive. Okay, well, the half-life of this is just a few seconds. Okay, so what you do is you can take an image of the brain, and it tells you what the metabolism of the brain is. So because the brain is the one that uses the most glucose of all the organs. And so now you take an image, and so the way this works is that you have a scale here, and 2 is white, and 0.1 is almost black. Okay. So these hot colors over here means that there's increased glucose going into the brain. These dark colors here means there's decreased glucose. The center of the brain has fluid in it, so you never see much activity here. But the outside of the brain is where you have the neurons. It's called the cortex. So you see a lot of activity here. So on top, you have all these individuals. They took this and put it into one summary slide here at the bottom. And you can see that the cortical ribbon here, the outside of the brain, lights up really well, right? Now you look at these patients who have this COVID, and you can see that in the middle one, you can see that it's, relatively red. Here it's not bright, right? So there's decreased glucose being taken up by the brain on both sides of the brain. So that suggests to you that the brain is abnormal here and it's not functioning properly. And the front parts of the brain are the most affected, the frontal lobes. This is a study from the UK, and what they have a National Health Service, so they have medical records of all the citizens in the country. And so what they did was they took 600,000 people and they analyzed what was happening to them. And they compared it to individuals who had influenza or other respiratory infections. So this blue line at the bottom represents individuals who had other respiratory infections. The one on top is with COVID. And they looked for various kinds of things, strokes. They looked at damage to the nerves. They looked at dementia. They looked at psychiatric diseases. Excuse me. But no matter which one you look at, you'll see that it's increased in individuals who have had COVID. Okay. So compared to that. And the bottom scale is number of days. So you're looking at up to 6 months or longer. So even at 6 months, you can see that all these manifestations are much greater in the patients who had COVID. Okay, so if we have patients with long haul, what are we going to do for them? Okay, so I told you that a lot of these patients had pretty mild symptoms to begin with, and now they're complaining of all these things. So one possibility that a number of us are considering, is it possible that they never mounted a strong enough immune response to get rid of the virus, and maybe the virus is still lingering there in some form or another, and they're not infectious any longer, but they still have parts of the virus there. If that's the case, then we need to treat them with antivirals in order to treat it. But we don't have any. So you want to treat them with antivirals, but we need to develop them. We don't have any. And then you can, but I also told you there were immune cells were abnormal, right? And so those macrophages were very active. So now what you could do is you could suppress those macrophages, right? But what I did not tell you here is that the macrophages are very active, and the reason they're active is because the T cells, which are the other cells, are not really functioning very well. They are exhausted. There's markers of exhaustion on them. So what you can do is you can reverse that exhaustion and maybe make those T cells active. And if you make those T cells active, what they will do is, if there is any virus, it'll find it and try to get rid of it. Okay. So you could, by manipulating the immune system, take care of both aspects. You could fix the macrophages, and you could fix the T cells and get rid of the virus. Now, the other thing is the vaccines. So the vaccines are very safe, but we started to see some neurological complications with them. And some of the complications that you see with them are reminiscent of what we were seeing with COVID. So in certain individuals who may be genetically susceptible for whatever reason, we're seeing some neurological complications in them. But if you see them, they're treatable with corticosteroids, because here there is no virus, it's just the protein. And it's stimulating the immune system to do this. And you can treat them with corticosteroids. But it's teaching us a lot about what's happening with long haul COVID by studying these patients who develop neurological complications from the vaccines. So we've started 2 studies at NIH that I am the PI. There are lots of other studies at NIH, and so many so that it's even hard for me to keep up with them. But there are two that I'm involved in. Okay. And so the first one is a study in which we are seeing all patients, all comers. And so anybody who has any kind of neurological complication, we will see them. The second is we've screened over 400 people for this study, and we want to identify 50 individuals who have symptoms that look like chronic fatigue syndrome. Okay. And because we've been studying chronic fatigue syndrome for quite some time, and we don't have a clue as to what's causing that. And here are these patients who are developing chronic fatigue syndrome. So if we study them, here we know what caused it, and we know what virus caused it, that maybe that'll shed light on the other chronic fatigue syndrome patients. So we want to get these cohort patients. This should be a C. So patients who have chronic fatigue syndrome, another 50 who recovered from the viral infection but didn't develop any kind of symptoms. So I'll stop here. I want to acknowledge a number of people. All the neuropathology was possible because Rebecca Folkert, she contributed the brain samples to us. They came through the Department of Defense. And Daniel Pearl is a neuropathologist at Walter Reed, and he was absolutely critical in helping us make this happen. Marco Hefty is a neuropathologist at University of Iowa. He contributed a few brains to our study. And Eliezer Maslia is a neuropathologist here at NIH, and he looked at some of these sections with us. And these are the people in my lab who did most of the work that I showed you. And then we have people in our MRI center who did all the imaging of the brains. So I'll stop here and we can take questions.
Great, Dr. Nath. Thank you so much. What an informative presentation. I want to first introduce myself. I am Angela Mediquez Vasquez. I'm the Vice President of Body Politic. I'm also a long COVID patient. Have been sick for over a year now. I'm based in Los Angeles, and my day job is a children's activist and community advocate out here in Los Angeles. So thank you so much for having us. For our viewers today, did just want to remind you all that Dr. Nath cannot give medical advice. So as we collect your questions from the YouTube comments, as well as our Body Politics Slack, please keep that in mind. And we are going to start with some of our questions that have proved most popular amongst our group. The first one I have, so you talked quite a bit about sort of brain pathology and neuropathy, and what a lot of long COVID patients found is many of their symptoms line up with some sort of post-concussion syndrome. And so curious if you could help articulate sort of the connection between long COVID and things like a traumatic brain injury, including, autonomic dysfunction is also present in many folks who have experienced a concussion. So.
Yeah, so I think that's fair. Post-concussive syndrome can produce a lot of different symptoms that last. And there's overlap between all these diseases, chronic fatigue syndrome, post-traumatic stress disorder, Gulf War syndrome. You have all various types of names for them just because the initiating factor is different. And so the precipitating factor gives the name to the syndrome, but the ultimate outcome and overlaps a lot between each of these. There may be some specific things to each one of them, but they do overlap. So I think that's fair. Yeah.
Got it. Thank you. So in your presentation, you did reference sort of exercise intolerance, but I'm curious if you could explain the symptom of post-exertional malaise and how that is similar to and different from exercise intolerance. Yeah.
So if you'd know, malaise is an interesting term. You can only describe it if you experience it. So physicians try very hard to explain malaise, and they never do a good job of it because they haven't experienced it themselves. The best person to explain it is the person who actually experienced it. So what I can do is I can only tell you from what I understand it. But it's a very strange feeling of unwell feeling, just feel terrible, right? And everybody thinks of malaise somewhat differently. In fact, Barbara was one of our nurses here at NIH. She published a paper after interviewing all these patients who describe post-exertional malaise. And the number of terms that people used is unbelievable. So she tried to produce some kind of consensus for it. And it was published in Frontiers of Neurology, and it's worthy of taking a look at it and to see what you find. But the most important thing is, no matter what you use to describe malaise, that is post-exertional. Okay, and I think that part we all agree on. So so the British had talked about something called pacing, and people hate that. So the idea was that if that after a while you can get deconditioned, because every time you exercise you're getting fatigued. You say, well, I'm not going to exercise for a while. Now you get deconditioned. So people say, well, if you get deconditioned, what you need to do is you need to actually exercise gradually, and maybe that'll make you better. But the patients tell you, oh, no, we don't want to do that, because if we do any of it, then we're wiped out for the entire day. We're gone. So it's a very strange phenomenon as to why with exertion get totally fatigued. So people say, well, this suggests that either there's a heart problem, because if you exert and you get fatigued, your heart has to pump, and your heart can't pump. So people studied the heart extensively, and there's nothing wrong with the heart. They don't know what to do. So then I said, well, maybe it's a mitochondrial problem, because the mitochondria produces all the energy. And so maybe the mitochondria are exhausted, and if you try to push them, they're going to get even further exhausted. And so, yes, you can find some minor abnormalities in the mitochondria, but it remains controversial, and we don't have a finite answer for it, a final answer for it. So I don't know exactly what it is, but it's a very interesting phenomenon. And we are very eager to try to find that out. I mean, I'm very curious to figure out how on earth and why this really happens. And all this testing conventional thinking doesn't provide answers to these things. I think that's the fascinating thing about it.
Great, thank you. In your presentation, you did mention headache, but I'm wondering if you could talk a bit more about the connection between long COVID and migraines and the symptoms that are associated with migraines. So vertigo, dizziness, a lot of people talk about a burning brain or pressure in their head. And we're a group of very smart, empowered patients. So someone also specifically asked if you could address the connection with CGRP, or calcitonin gene-related peptide.
Yeah, sure, absolutely. We're delighted to. Okay. So the thing is, if you look at headaches in the population, ask the entire population, have you ever had headaches? Okay. You find that about 50% of the population, or maybe slightly more than that, have headaches. So this is an interesting thing that somebody explained to me. He said, okay, how do you define what is normal in a population? He said, well, if a majority of people have something, then it must be normal. So he said, well, if that's the case, and more than 50% of the population have headaches, then headaches must be the norm in the population. Those who do not have headaches are the ones that are abnormal. I never thought of it that way, but I said, okay, well, this guy has a point. So headaches are very common, but the thing is, they're devastating. So I wouldn't go to that extreme. I said, we want to get rid of the headaches. But headaches can be triggered by a lot of different things. Okay, so if you have a history of migraines, or even if you didn't know you had a history of migraine, but you have a family history of migraines, and the precipitating factors can be many. So an infection can do it, certainly. It can be allergies can do it. My famous one is that on close to Mother's Day, if you go nowadays, you don't go in the mall any longer, but in the days when you did, there's these, they're sitting there with all these perfume, just pushing them. You buy these perfume, and they keep, and if you are allergic, if you have migraines, one puff of that, and boom, your headache explodes. So a lot of things can trigger migraines, but the thing is, it doesn't matter what the trigger is. You treat them all the same way. Okay, so if you get frequent migraines, you got to prevent them from taking place. So we have a whole slew of drugs that we use in order to prevent migraines. If you get them infrequently, you treat the acute episode. And there we have the triptans and the CGRP antagonists now. And there are 5 CGRP antagonists that are now approved. Some are antibodies, so you got to infuse them. One is given subcutaneously, and then one now we have an oral form of that too. Okay, and so but they're very effective. And that's the latest buzz in the headache treatment world now. So don't worry about what the underlying cause is. You treat them the same way. Now, sometimes headaches don't always necessarily mean migraines. I mean, you can get headaches from brain tumors, and you can get headaches from meningitis and infection and other things. So if it says a new onset headache, you've never had headaches before, you should certainly see a physician to make sure there isn't some other cause for it. But once those things are ruled out, then you treat them the same way.
Great, thank you. We do have a question asking you to clarify what you meant by pacing. What does that look like for patients?
Oh, pacing, yeah. So that's something you don't want to do. But what it is graded exercise. Okay, that means you do a little bit of exercise. One day you, for something, you get tired, you relax, then you do a little bit extra exercise, whatever you did last time, now you bump it up a little bit. And then so gradually, if you keep increasing the amount of exercise that you can tolerate, the idea is that at some point you'll come close to normal, or the maximum that you can do. You're better off from where you started off. So the rationale behind it makes sense if you were truly deconditioned. But for these post-exertional malaise or patients who have the ME/CFS, there it's a problem. The pacing doesn't actually help them; it actually makes them worse.
Got it. Interesting. Okay. I'm curious if we could move to sort of research and looking ahead. What potential treatments, clinical trials, or research are you most excited about related to long COVID?
Well, the thing is that what I'm excited about is that Congress appropriated $1.5 billion with a B just to study this long COVID phenomenon. Okay. I mean, that's the most money you would ever get or ever hope to study this phenomenon that has far-reaching consequences for all these other syndromes that I described, the Gulf War syndrome, the ME/CFS, the post-traumatic stress, all these things. In my mind, they're all under the same umbrella. But the money has come for long COVID, and as a result, the first group of grants have now already been submitted to understand the pathophysiology. I think what I'm told is about 270 some grants were submitted from all around the country. And I don't know what's in those grants, because obviously those are all confidential at the moment, but eventually that will become publicly available. But the fact that so many groups of people are interested in studying this around the country, that's unprecedented. Okay. So what I'm excited about is once these studies get going, and the federal government is not the only one pumping money into it. We have other agencies looking at it as well. That we should, if we don't understand the pathophysiology now, we will never do it. So I'm excited with some answers will come up. Now there's going to be a second phase to this thing. And they're going to now invite proposals for clinical trials. And my guess is you'll see the same kind of enthusiasm for clinical trials too. So we should not only understand the disease, we should find reasonable treatments for the disease too. With this, and that I think is the most exciting thing that's happening at the moment.
Got it. And do you think these research efforts, if there's an appetite to sort of pursue existing research and deepening the research on ME, on POTS, mast cell activation, what are your senses of?
Yeah, they're all, each one of them will be studied. So you don't have to, one doesn't have to compete with the other.
All right, we're going to hold you to that.
Just study them all.
Great. So one question that comes up quite a bit for folks in our support group is sort of, it's clear that long COVID is some type of like sub-ideal immune response to the virus, viral persistence or autoimmunity or autoimmunity. And then given what we're seeing with T-cell exhaustion, could studying long COVID patients without positive tests, but who clearly demonstrate an acute COVID phase with those established symptoms, hold the key to understanding the full progression of long COVID without much intervention over several months?
Yeah, so, I think that's very, very important. We should talk about this some more. And that is that, there are a lot of patients who, for whatever reason, were unable to get tested at the right time. Okay. And then later when they got tested, the tests turned out to be negative. They had classical symptoms of COVID. And so you can develop a clinical definition of the disease. You don't have to have a laboratory-based diagnosis. I mean, laboratory-based diagnosis is certainly definitive, and clinical diagnoses do have some pitfalls. But with a reasonable amount of certainty, you can develop a clinical diagnosis in a patient. I mean, they have loss of smell. There are a number of things that are quite typical of COVID that don't occur with other respiratory illnesses. And the timing also, a lot of other respiratory diseases disappeared during the when COVID was around. Early phase, it was hard because they were circulating. But after that, all the other respiratory viruses disappeared. So you can develop a clinical definition and then you can study them too. I don't have a problem with that. I think that's, a lot of people are going to do that anyways. Yeah.
Got it. Do you think there's appetite within the greater research community to do that?
Oh, yeah,
we hear a lot of pushback from, journals won't publish us if we don't, confirm people's
that's a problem. Yes. Yeah, there are problems. There's no doubt about it. Yes, I myself have rejected some papers for journals where it wasn't entirely clear this patient did or did not have COVID. And we've turned down some patients for some of our own studies too. So yes, there are issues, but despite those, a lot of people are very interested in trying to study that population. And there are other things you can do too. What you can do is you can do cell-mediated immune responses. So you may be able to figure out if a person was exposed to SARS-CoV-2 or not through other mechanisms. They are much more complicated tests, but in a research setting, it can be done. And not everybody can do them. But and you don't have to study everybody. You just need a cohort of patients, and a small cohort, you can understand a lot from that.
Got it. Thank you. And again, another research question. Are there any studies that will be doing tissue biopsies to look for persistent virus in long COVID?
Yeah, I don't know. All those, actually, there's 200 some grants submitted, so I'm sure some people are probably doing things. There's at least a paper published in Nature. They showed where they did intestinal biopsies, and they showed they could find a viral antigen there. And this was like 4 months after these patients had recovered. And so, yes, there is an interest in it. The problem is that how invasive can you be? And what can you buy? You cannot biopsy brain tissue. So where are you going to go? Maybe you can. And lymph nodes are not easy to biopsy either. Unless they're swollen, then you can get them. But otherwise, you could cause a lot of trauma. So getting to tissues is not an easy task. I mean, you can biopsy the lung, nasal mucosa, but the nasal mucosa, the part on the outside, you're not going to get much. You got to go deep in to get the viral reservoir, and that's dangerous because you could perforate the cribriform plate in somebody. So it's not that easy. You'd like to get tissue, but how do you do it without hurting people is not an easy task.
Got it. Thank you. Super helpful. That sort of brings up this question around gastrointestinal symptoms. We have a lot of folks asking about the brain-gut axis and if gastrointestinal issues may be neurologically based.
Yeah, it's quite possible. It can go either way. You have problems with the intestine and it can affect the brain. In fact, one of the hypotheses that still remains unproven is it possible that the virus can go along the vagus nerve from the intestine all the way to the brainstem? Because this is called the vagus nerve. And the vagus, I showed you the pre-Bartzinger complex there. The vagus nerve nucleus is right close to that. Okay. So, and the vagus nerve innervates the intestine. It also innervates the trachea and in your respiratory system. So you have virus in the respiratory system, you have virus in the intestinal system. And it's the same nerve that's supplying it. So it could go up the vagus nerve and go right through the pre-Bartzinger complex. Now, nobody's shown that occurs, but it's a theoretical possibility, right? And I mean, the brain controls all organs. So the thing is, now the brain is affected, can affect the GI system. Of course, it can affect the GI system because the vagus nerve innervates the GI tract. So it can go either way.
Great, thank you. Heading back into symptoms. So there's folks who are asking about sort of what's your estimation, timeline and possibility for recovery, particularly from the cognitive effects of long COVID?
Okay. Yes. So your recovery after the acute infection, a lot of people, I told you about a third of the population has problems with it. And these patients do get better. Most of the recovery occurs early on. Within the first month, you'll see a lot of patients get better. And then by the second month, you'll see more people get better. If you do not improve by 6 months, then the chances of recovery are still there, but they become greatly diminished. There are some people who recover to up to a year or so, but beyond 6 months, I think one needs to be quite concerned that we need to look and see if there's some other problem that may be causing these symptoms. Is that all COVID?
Are there any interventions or rehab? Brain, folks are asking about brain rehab. Are there any that show promise based on your estimation?
It's not an area of my expertise, but there are psychologists who specialize in cognitive behavioral therapy. And so, yes, I mean, we do that for Alzheimer's patients and others too. So you can train the brain to function better than what it is, and use other parts of the brain to take over function of parts that are damaged. And so that's the basis of cognitive behavioral therapy. But yeah, brain is like a muscle. You exercise it, it'll do better. And so you don't want it to sit idle, that's for sure.
Got it.
I got to tell you a story here. So, there was a nephrologist who invited to give grand rounds, this guy, Andrioli. And so he said, okay, we're going to talk to a bunch of neurologists. What do I tell them? He started off, he says that the kidney is more important than the brain. So that caught all our attention. He said, how's he going to pull this one off? What's he going to say that the kidney is more important than the brain? He said, listen, if you don't use your kidney, you're going to die in 5 days or 6 days or 7 days or whatever, you ultimately die. He says, I know all these people who go around their entire life and they never use their brain.
Ouch. Yeah. Well, speaking of trying to use one's brain, there's let's see if I can combine some of these questions. So a lot of questions about fluctuating muscle strength. And then there are folks who are, at least for them, are associating their muscle strength and ability to coordinate their muscle strength, their muscles, with problems with language. Do those symptoms sort of make sense to you from a neurological perspective? I think the question is sort of, when I feel uncoordinated or weak, I also struggle with language issues, I think is what I'm reading.
I guess maybe you're just focusing on trying to control your muscles so you can't think about other things because your brain is occupied. You're putting all your energy in one place. The other parts of the brain may not be able to function as well. That's the best explanation I can come up with.
Got it. Also have a question here about sort of what might be the explanation for a sensation of, quote, brain torture when I overdo cognitive tasks.
There's no torture to the brain. The brain loves to be exercised. I torture mine every day.
Good. Well, I guess my question in interpreting this, my question would be, could you explain sort of cognitive fatigue or sort of cognitive effort linking to fatigue or post-exertional malaise?
Yeah. That's a real thing. So just like people complain when post-exertional exercise intolerance that I was talking about, the exercise intolerance is not just muscle fatigue, it's cognitive fatigue too. So they complain of both issues at the same time. Yes, that's a real problem. But the thing is, they tell me they can't think properly after they exercise. And then it takes them a long time to recover.
Got it.
Same phenomenon can occur in both. Yeah, that's true.
Got it. I do want to jump back to research, and particularly your research. If patients are interested in participating in the research you mentioned, can you describe their requirements and how they can get involved?
Yeah, so there's a website also, and they're called clinicaltrials.gov. Okay, And so we have both our studies are there. It has inclusion criteria on there. You just put my name and put COVID or something, it'll show up. And then we have the contact information for my nurse, and so you can just contact her. And we've even created a email address called NINDS post-COVID, and so and you can email them, and they will let's see if you are eligible for our study or not. And you'll find a lot of other COVID studies. I think depending on where you are, which geographical region you are, I would encourage you to get into some study or another, because the family physicians can only do so much. And then after a while, patients all get frustrated and say, well, my patient doesn't believe me any longer. My physician doesn't believe me any longer. The thing is, the poor guy doesn't know what else to do. So but these studies are looking for individuals like you. They want to study you. So, and as I told you, 200 some studies are going to be on, maybe many more are going to be around. So I think you need to try to find where these studies are taking place and get enrolled in them. And they're going to be consortia. So all these studies that get funded, they're going to be talking to one another. And we're going to come up with similar kinds of ways of investigating people, share data and stuff. So you're not disadvantaged by being in some study versus the other. Just get on any of them.
Great. Hopefully their eligibility allows for folks like me who do not have a positive test to be enrolled in those.
Yeah, that's right.
I think related to what you were just talking about, many of us have tried and failed to get our doctors, including neurologists, to take our symptoms seriously. So do you have any general advice about how to educate our current providers in what to assess and how to treat us?
Yeah. So you're absolutely right. It's very frustrating. You go to a physician and you're going with some hope, and there you go, and they say, well, I don't think there's anything wrong with you. So it's very disappointing. But look at it from the other perspective, from the physician's perspective. All the physician can do is, even if they say, yes, I understand your symptoms, I agree with all of you, here are the tests that I can do, all the tests come back negative. Now, what's the physician supposed to do? You see that? You can say, okay, I believe you, but I don't have anything I don't know what to do with it. And so I think that's where most of these people sit. And so it's true that we need to educate physicians to say that, okay, if you cannot do anything, at least say you believe this patient's symptoms. And so that at least you give them that psychological comfort. But the reality is that they can provide you the psychological comfort, but they still don't do anything about it because they don't have the tools that are necessary to treat these patients. I mean, like nobody does. So instead of putting all our energy in trying to tell these physicians, don't say this, just forget about it. Let's just go ahead and do the trials and the studies that are going to find real answers. And once we have a treatment, then we give it out to these physicians and say, listen, patient comes with you, this is what you need to do. You fix their problem. Then you'll find more acceptance. Otherwise, you just keep with that argument that's been going on for decades with the ME/CFS patients. We haven't solved that problem. And putting all your energy in that doesn't help you much. Fix the problem. That's where you need to put your energies.
Got it. Thank you. We do have a question about persistent anosmia. I'm saying that wrong. Yes. Does this help diagnostically for an ongoing process that can still respond to treatment, or is the anosmia seen as permanent?
Well, it depends on how long you've had it. So most anosmia gets better after the acute infection. There are few people that do not. If this has been going on for a few months, then chances are it's not going to get better. There's some people who get parosmia. Parosmia is a term. What happens is that they initially lost the sense of smell. When it comes back, things smell very strange now. They don't smell the same. In fact, this is a interesting interview I had. This was with BBC radio, in Northern Ireland, and they brought in this patient, and they were interviewing her, and they asked her that, can you describe what happened to you? She says, I lost my sense of smell, and when it came back, sense and smell and taste, she says she lost. And when it came back, now things strange, so strange. She said, every time I brush my teeth, it tastes like dog poop. Okay. And so the reporter then asked me, he says, "Doctor, what are you doing to fix these problems?" And I'm thinking to myself, I don't know what to do to fix this problem. And so I said, well, I need to ask this patient a question. I said, how does she know what dog poop tastes like?
Ouch.
So, but I got saved by the bell, because at that time he said, we got some breaking news that had to do with Trump or something. And that was it.
Oh, man. So sorry to jump back a little bit. We have a couple of folks asking if there are specific imaging, and I'll say imaging and or tests or procedures that you recommend sort of we push for.
So the imaging hasn't really shown much. I mean, you can get an MRI scan. For most of the long haul COVID patients, imaging has been normal, because they're using the imaging that is available to you is a 1.5 or 3 Tesla magnet. And the ones that I showed you, the imaging where you saw these abnormalities, those are 11 Tesla magnets. And there's no, the way we managed to do that, the 11 Tesla magnets are actually animal magnets. And we put human brain in there, but those are autopsy brain tissues. You see that? So you cannot put a live human in an 11 Tesla magnet quite yet. I mean, pretty soon that's going to be possible, but at the moment you can't. So let the neurologist make that decision if they think that the imaging is going to be helpful or not. If you're in a clinical study, I mean, almost everybody will get imaging because of the clinical study. But for clinical practice, you have to make a judgment as to whether the imaging is going to be useful or not.
Got it. And I've heard that participating in research is one of the best ways to get sort of that really granular information about your own body, which I think could just help support patients psychologically.
So you're absolutely right. I mean, I am a strong believer that we all need to participate in research studies. The reason you and I are alive today is because somebody donated their body to research, right? If they didn't, we would have been long dead. All the treatments we have available for various things because somebody went in research. So I think it doesn't matter what disease you have. It's our obligation to society to participate in research. Yeah.
Well said. We have just wanted to do a time check. We have about 12 minutes before we need to wrap, and I do have a couple of more questions. How many, or sort of, are folks, and how many, by your estimation, are getting limbic encephalitis, and how are you detecting this?
Limbic encephalitis is it's a rare disease, and even with COVID, it's very rare. So I've heard of a few cases, but there can't be that many of them. But limbic encephalitis is a very devastating disease. You won't be walking around with it. I mean, most people are hospitalized. They're pretty sick. They got seizures. They got massive cognitive abnormalities, swelling in the brain. And diagnosing is by MRI scan. And there's specific antibodies you can look for that can cause limbic encephalitis. And then you got to treat them very aggressively. They got to treat them in a hospital. We do plasmapheresis and IVIG and all kinds of other things to treat them. That's a very serious illness.
Got it. Got it. You've mentioned seizures several times, and I'm wondering if you can sort of talk about how folks would know. I've noticed a lot in our conversations on the support group. We guess at that we may have had seizures based on some of our symptoms, but I'm wondering if, sort of clinically speaking, how would we know, how would patients know whether they're having seizures or not?
Yeah, it may be hard because there are many different types of seizures. You see. So one is called the grand mal seizure, where you actually lose consciousness, your whole body jerks. That's the most dramatic form of all. And that, when you have those, you call 911. I mean, that is so dramatic. So, and then there are what is called focal seizures. Okay, so focal seizures, sometimes what you get is you get the focal jerking of your arm or leg that lasts for a little while and then stop. And but it's usually one-sided, and it's a very rapid jerking, and it's very different from tremor. People mistake tremor for seizures all the time. And so tremors last for a long time. Seizures last for short periods of time. It's very rare forms that are called status seizures, but They usually occur if you have brain tumor or something like that. The COVID shouldn't occur. And then there's something called complex partial seizures. Those are called automatisms. So those are, you will get loss of consciousness. They may be talking to you and they lose consciousness for brief periods of time, and you'll see some automatized movements of the lips or face or something that occurs at the same time. That takes clinical acumen to diagnose. It's hard for patients to figure that out. But yes, a wide variety of seizures, and so some you may be able to pick up, and others may be hard. Even for neurologists, sometimes diagnosing seizures can be hard.
Got it. Thank you. Helpful information. Diving back into sort of immune system therapies, are there any specific drug treatments or maybe trials looking at boosting T cells?
Yeah, so I mean, currently there are no trials, but people would like to do trials. I mean, if you want to boost T cells, there are a number of things you can do. You can, if you have exhaustion markers, you can reverse them. They're called checkpoint inhibitors that we can use. We use them for cancer all the time. So a lot of T cell exhaustion has been studied in the cancer. And, the Nobel Prize for checkpoint was given out last year for cancer. And it was the same thing where they figured out how to activate these T cells that go and attack the cancer cells. And so there are a whole host of things that the cancer docs have used. And so the pembrolizumab, novolizumab, there are anti-PD-1 blockers that you can use. There are antibodies used to reverse T cell exhaustion. And then there are other, so they attack what is called PD-1 is a molecule of T cell, but there are a number of other checkpoints too. So you can try to reverse a number of those things and not just one of them. Then you can divide T cells. If the T cells are low, you can actually divide them too. So people use IL-2 to proliferate T cells or IL-15 to proliferate them. There's another called IL-7. These are interleukins that will act on certain populations of T cells and cause proliferation of those cells. So in patients who are immune suppressed, you can actually use those kinds of mechanisms. Yeah, they're available. They're not without side effects. They have their own profile, so you shouldn't take them lightly. And that's why I think if you're going to do them, you should do them in the context of a clinical trial.
Got it. Thank you. To head back to symptoms, we touched on this a little bit in the question about migraines, but there's particular questions about tingling, pressure, and other sensations in the head and brain. Do you categorize those as headache symptoms, or are they a separate sense? A lot of folks talk about these symptoms without headache pain.
Yeah. So the tingling can represent a number of things. It could represent a peripheral neuropathy. That's one possibility. It can represent hyperventilation. If it's only in the face or mouth or something, if you're anxious and you're breathing, if you just try that, just breathe very rapidly for some period, wash off your CO2. You'll get tingling around your nose and mouth and stuff. So that's, and people who are anxious, they're breathing very rapidly. So that could be just related to a loss of CO2. Then there's something called Reynolds phenomenon, whereby you have abnormality in the blood vessels. The blood vessels, like rheumatoid arthritis patients will have it, or lupus patients, where your blood vessels just constrict. And so your hands can become a little bit purple and you get tingling in your hands and fingers. But that's a vascular phenomenon, not a nerve phenomenon. So there are multiple reasons for tingling, and doesn't have to be migraine. No.
Got it. And so moderator privilege follow-up question. I've developed Raynaud, and I've noticed
really?
my neurological symptoms are very correlated. So is there a potential correlation between?
Yeah, it could be. Yeah, it could be an abnormality in the autonomic nervous system. And so you can get either hyper or hypoactive autonomic nervous system, and that can constrict the blood vessels leading to this. So they could be very well be related. Yeah.
Got it. We have about 5 minutes left, and we have a couple more questions. Have you seen any research being done on neuropathies as a consequence of long COVID? Then there's a question about kids, or neuropathy in kids. Have you seen any research on neuropathy in kids?
Yeah, and the kids part, I don't know. There may be things, but I may not be aware of. But the neuropathy, I know a lot of people are interested in. Yeah, we are interested ourselves too. There's a woman, Oaklander, at Mass General. She's very interested in it. There's another guy, Delakas, in Philadelphia. He's interested, and there are many others, I'm sure. So neuropathy is bread and butter for neurologists. If they see it, they all study it. We have a whole subspecialty in neurology called neuromuscular disease. That's all they do is study neuropathy. So they'll jump on it when they see it.
Got it. When do you expect phase 2 / treatment trials will happen? Right now, it seems like we're trying to figure out the what's going on.
Yeah.
When do you expect us to head
Yeah,
into?
so I think it's as soon as these grants get announced, I'm sure some people are probably already doing something, but on a large scale, it's going to happen once these grant announcements come out. So I don't know what the time frame is, because I'm not in the extramural NIH, I'm intramural, so I'm not privy to all that information. But NHLBI, which is the Heart, Lung, and Blood Institute, they're the ones who are administering all these funds. They got the lion's share of it, and NIID. And NINDS didn't get a penny. So they're the ones administering it. They would know. My guess is that they were thinking of funding the pathophysiology one sometime in June. So once they do that, then but the same people working on these things. So, once they get one part done, then they start working on the next one. So it could be by the end of the year or something is my guess. I don't know. I have no idea. Maybe they'll be sooner. I don't know.
Got it. Thank you. Could you comment generally on the scientific opportunity presented by long COVID, and what are the most important steps for capitalizing on it?
Yeah, so here you have to, I can tell you my take on it, but a lot of other people will look at these things as opportunities to study whatever disease they were studying on previously. But all the diseases that we talked about in the past, the POTS, the Gulf War, the chronic fatigue, all these things are going to benefit from studying long COVID. But there's a lot of new technology that's going to be thrown at it too. So the chances are we might develop new technology to study the immune system, because just as you said, people are infected, we're not figuring out if they're infected or not. So maybe we'll develop new technology to try and figure out these things. Whenever a question poses a scientist, they don't have the answer to it, they will develop new things. And so you may not be able to even forecast what's going to come out of studying long COVID today. And but that's the fun about science. It never goes the way you plan it. It always goes in a direction that ultimately fascinates you. And the end result is better than what you can ever imagine. That's how discoveries occur.
Yeah. All right. So I think we're going to wrap up with this last question, which I think is maybe one of the most important for you here. There are a lot of long COVID patients who are suffering symptoms daily, struggling to get care from their doctors. Do you have any words of encouragement or hope to say to them?
Yeah, of course. There's no way you should lose hope. Just look at the amount of every single scientist or physician was sitting at home when they COVID for a whole year, okay, trying to figure out how do we get out of here. So what are these people doing? They're thinking about what can they do, whatever expertise they have. How can they apply it to studying COVID? People who have never even heard of a virus, they're applying their expertise to study it in whichever way, whether they study the structure or something, or they study treatment for something, or they develop new drugs to screen against the virus, whatever it might be. So the most brilliant of brilliant people have all focused their energies to study this. So they've got to come up with something, I'm pretty sure. And so much funding has been appropriated towards it. People have been doing, even without funding, people are applying whatever they had. I had AIDS funds. I was just using that for studying COVID. And so even before any money, to date, I haven't received a penny for it, but whatever money we had, we've applied towards it, studying it. So, you have a whole world full of scientists and physicians who have devoted their energies towards studying this thing. So I think I am very hopeful that we'll come up with something.
Great. Thank you so much. Thank you so much for your presentation, for your time answering all of our questions, both technical and theoretical. I want to thank everyone for watching this. Share it, please, with your family and friends, patients, and clinicians. Thank you to Shamir for kicking us off. And thank you to our behind the scenes volunteers and Body Politic administrators, Marissa Oliver, Lindley Schwartz, and Rachel Robles for making today happen. And on behalf of Body Politic, the grassroots organization at the forefront of the patient-led movement for long COVID, thank you for joining us wherever you are. We are an entirely volunteer-run organization made up of largely COVID-19 patients. If you'd like to support our work, please contribute to our GoFundMe campaign, which should be linked in the video description once the video is uploaded. Thank you so much, everyone.
Thanks for having me. It was a
Of course.
great pleasure and an honor to be with you.
Great.
Okay, bye-bye.